here to invite Professor Dheeraj Khurana, Professor and in the Department of Neurology, PGI Chandigarh. Sir has done MBBS and MD from DMCH Ludhiana and DM Neurology from PGI Chandigarh in the year 2000. His major achievements are in fields acute stroke, multiple sclerosis, and neurosonology. He's also a lifetime member in the Indian Stroke Association, IAN, and Neurological Society of India. I would like to invite Professor Dheeraj Khurana for the next session. That is, the topic is small vessel disease and emerging concepts.
Yeah. Okay. Thank you. Thank you for the introduction, and good afternoon, everyone. Professor Padma, Professor Lal. Today, as I've been asked to talk about emerging concepts in small vessel disease, the only thing what I'll start with is small vessel is nothing small. Remember that. And when we were learning neurology, when we were training, interestingly, small vessel disease was not given much of importance. Many times we would look at the patients who had come for other complaints, and we would see such kind of MRIs. We were told these are just age-related changes. Forget about them. Nothing to be done. Something like something which was also considered as even reducing memory. So at one point of time, it was considered that people start losing memory at 60, so forget about it. Now, over the years, we've learned that that's not normal, and we need to do something to change or alter or modify the occurrence of these kind of occurrences, events. And so is the case with small vessel disease. It's no longer as important as we thought when we called it leukoariosis, for example. And that's what the name was, leukoariosis, and there were multiple papers which would come and tell us. Well, now we know a lot about small vessel disease. A lot of information is emerging, but just to put it in perspective, this definition is what you would expect it to be, what you see so commonly in MRIs. It's a small perforating arterioles, capillaries, and probably venules too, as per what we understand now with enhanced understanding, which cause small lesions which are seen on the MR or CT on imaging, and are also seen correspondingly on pathological examination of brain imaging. And these, exactly as the name suggests, are those small little white matter hyperintensities or hypointensities you see on the CT in white matter or around the ventricles. So these in a range could be, and interestingly, they not only lead on to infarcts, they're also now clearly known to be associated with hemorrhages. And they are of presumed vascular origin, and they manifest themselves as either lacunes, which are small, less than 1.5 centimeter in size lesions, microbleeds with superficial siderosis. Now, perivascular spaces too are part of small vessel disease, which I'll show in the subsequent slides. Small infarcts too. So, for example, in this very characteristic MRI, which you, like I mentioned, is a commonly seen finding in a lot of our patients. So small vessel disease would either be typically seen as either small, less than microinfarcts, lacunes, and maybe not very clearly seen are linear hyperintensities. Maybe I'll show you this one. This one shows these hyperintensities, which are a bit linear. If you see them very carefully on your scans, these would be linear rather than round or oval, and these are perivascular spaces or the Virchow Robin spaces, and these are part of the small vessel disease complex. Their features are many. Like I said, the most quite commonly what you see is a silent or an asymptomatic small vessel disease. And remember, it may not stay asymptomatic for long. It may just that you've not tested the patient enough. And with the coming time, the patient may not just remain asymptomatic. You may get dementia. And sometimes if you just, a classical case of dementia, if you do an MRI, you will see small vessel disease along with it. So mood behavioral changes, reduced mobility, these are some of the features which it is associated with. So, and not only these, there are important clinical implications associated with small vessel disease. There is now, we know that there is an increased risk of stroke. So in a patient who has small vessel disease accumulating, this he may get on to have a, although may have a minor stroke, but these are definitely associated with risk. And not only that, once a stroke happens, small vessel disease increases the burden of the stroke and is associated with worse outcomes. Now, if we are to look in general, the importance of SVD, that would be obvious if we understand the burden of disability and stroke which small vessel disease causes. Uh, Very importantly, there is an massive increase in health burden of stroke and dementia associated with it. You can imagine that almost 1/4 of ischemic strokes and almost all the hemorrhagic strokes which you see, which we used to call spontaneous ICH, is no longer considered spontaneous ICH. The background is a small vessel disease. Dementia, significant number of patients have vascular changes in the form of SVD, and most commonly you'll see it associated with Alzheimer's, and it leads on to further worsening of cognitive impairment in patients who have dementia. So that's an important contributing factor for increasing or worsening dementia. And overall, around 50% of dementia worldwide may be contributed by SVD. So it's not a small matter to be considered. So most importantly, I've been asked to talk on emerging concepts. If we understand the mechanism and pathogenesis, that is what is the most important thing behind the small vessel disease. Reason being, all the treatments or managements would be focused on these areas. And it's not simply a occlusion of small vessels. There's a big complex which is involving even the normal tissue which is around the blood vessel. So it is nothing which is restricted to the blood vessels. And this has been gleaned over time when it was seen that not only the area which was supplied by the small vessel disease damaged, even the areas around that and distant from the major site of involvement of the small vessel disease gets damaged. And one of the common risk factors, which is as probably known by all of us, is hypertension is extremely common risk factor. Just referring to the pathology, which was initially described by C. Miller Fisher, it is seen in the small arterioles, which are less than 0.1 mm in size, the arteriosclerosis, lipohyalinosis, very commonly heard terms, fibrinoid necrosis, which indicate that likely all these processes cause occlusion of these small vessels. However, if we see carefully, the capillaries are also abnormal, the venules are abnormal, and sometimes even in the absence of hypertension, the abnormalities in the arteriolar and the other small vessels are seen. The most important thing, the injury is not just in the periarteriolar region, so that cautions us. It is not a simple disease as occlusion of the small vessels. We must remember it. There is a complex pathogenesis. And what is a complex pathogenesis? Something which we always used to avoid when we used to read pathology and the pathogenesis of diseases. We would avoid all the basics, but this is the important thing in small vessel disease. To learn the basics, the neurovascular unit forms the basis of the pathogenesis and where the damage happens. And this neurogliovascular unit consists of the capillary endothelial cells, the pericytes and the astrocytes, the foot processes of the astrocytes, and the oligodendrocytes and the micro. You know the functions of all these cells. The capillaries, they are responsible for the vascular part. The astrocytes and the microglia, they form the supportive part and also are responsible for producing the myelin of the brain. So you can very well understand there's a complex thing of vascular as well as abnormality in the or damage to the axons happening due to poor myelin formation. So what happens, we know, is that endothelial cell dysfunction and the blood-brain barrier gets disrupted. So once the blood-brain barrier is disrupted, you would have more of interstitial fluid. You will have disruption of the astrocyte feet and end feet, as well as you have oligodendrocyte dysfunction. So myelin is impaired and normal astrocyte function is impaired, which impairs the neuronal energy. So something very simple, which looks like a small vessel which is going inside the brain getting disrupted, is not as simple. What we need to remember is that the blood vessel is going along inside the brain, and this is the perivascular space. So as it dips in, we need to understand the blood-brain barrier. So if we take a cross-section of the blood-brain barrier, we look at the perivascular space, the endothelium, its basement membrane, the pericytes, the astrocyte forms the foot process over here, and all of these are in the close proximity to the small blood vessel which is going inside. And therefore, this is the neuroglia vascular unit that I was talking about. And the interstitial milieu, which is maintained by the blood-brain barrier, has to get disrupted. And that, along with the foot process of the astrocyte getting disrupted, leads on to neuronal damage. So primarily, it's not only a vascular blockade due to lipohyalinosis, also damage to the astrocyte foot process to damage, and that explains the more distant effects of small vessel disease. Another important aspect, very close to my own interest, of cerebrovascular reactivity, since in transcranial Doppler, we give a lot of importance to VMR, and we try to tell the importance of VMR. A VMR, a very easy way to assess it is TCD, and what is VMR is not equal to cerebral blood flow. Remember that. So cerebral blood flow, people might think this is equivalent to the VR, but cerebral blood flow is static, whereas reactivity is dynamic, and we usually measure it as a result of a challenge. So you give a challenge like breath holding test on transcranial, or a diamox, which you very commonly see. And it is reflective of endothelial dysfunction, since you are looking at arteriolar changes or the arteriolar diameter change. And it tends to decline with age, increasing age, with blood pressure, lacunar strokes, and also increasing white matter hyperintensity. So in the another contribution to the small vessel disease is done by cerebrovascular reactivity is also abnormal in small vessel disease. And another important fact, remember that small vessel disease is not a screenshot. It is not a one-time event. You've got an MRI done, and you're going to take care of the risk factors. It is a progressive disease. And it is well proven by a number of studies that progression of white matter hyperintensities happen, and multiple mechanisms have been elaborated. Most studies have shown progress. Some studies have also shown shrinking and disappearance. And what actually happens is it expands into the adjacent tissue. So likely there is damage. It's believed that the tissue surrounding the initial small white matter hyperintensity, it also causes damage, and then there is progression. So clearly the extension happens along the previously present white matter hyperintensities, and in the superficial to them, and on the caps, as the small subcortical infarcts are called. And lacunes keep getting formed in the proximal margins of the white matter hyperintensities. And this is likely related to the perforating arterioles. If we look at that, along with that, like I mentioned, the distal changes and cortex starts getting thin. And that may contribute to even the presence of dementia and increasing cognitive decline. MRI has shown changes in the on the DDI with looking at DDI and diffusivity and fractional anisotropy, and clearly showing that the fibers, the white matter tracts, which are distal to the arteriolar lesion, the lacunar lesion or the small vessel, they show changes and degeneration, the Wallerian degeneration. So this is explained by the method which I explained in the previous slide, with disruption of the blood-brain barrier. So remember that small vessel disease is not just a disease which you see in the white matter add in the periventricular areas. It affects the whole brain. It's got a whole brain effects. And that's what emphasizes the importance of understanding small vessel disease. So, and we see diffuse changes in the normal appearing white matter as well as gray matter. If we look at these changes with high Tesla MRI, these would be seen, and even on the MRI, which I showed in the previous slide. So these which are seen on diffusivity would be seen much better with DTI, and this gives an explanation. So the many phases of small vessel disease, as I would call it, just like the brain of small vessel of human brain, it can lead on to stroke, cognitive problems, gait problems alone. In fact, the vascular Parkinson's, which we talk of, the lower body Parkinson's, I couldn't add a video. I had a patient's video here, couldn't add it. Are all a result of small vessel disease in these strategic areas. Mood changes, apathy, depression, and extrapyramidal, like I mentioned, it's a diffuse effect. It is not small lacunes or small strategic infarcts, but a diffuse effect on the extrapyramidal system. Another variant is a hemorrhagic. Like I said, all of the hemorrhagic strokes that you see, but this is not basically a hemorrhagic stroke that I'm trying to show, will have an underlying small vessel disease, which is seen very well on even when you do an SVI. We conducted a study some years back where we tried to look into the burden of small vessel disease on SWI, trying to relate it to the hypertension control, and we did find specific areas of small vessel SWI changes, micro, which were associated with hemorrhagic strokes and blood pressure control. And there are larger studies which have recently been published. Unfortunately, we couldn't publish earlier. So this is classically seen in amyloid angiopathy, which we've all probably seen quite a few times. And the manifestations are typically of amyloid would be acute ICH, usually small infarcts, and most of the changes of amyloid are seen in the periphery, not in the deep white matter. Cortical, and usually these are subclinical macro hemorrhages, microbleeds, cortical subarachnoid hemorrhages. Now, these are very important. Cortical, or they may be present in the sulcal hemorrhages. We've actually seen a few sulcal hemorrhages in amyloid, and they present with just seizures. So in fact, no deficit. Cortical superficial siderosis, which was seen in this patient also. This is a case of cerebral amyloid angiopathy. And the primary pathology we all know is the deposition of A beta amyloid in the vascular wall, leading on to damage to the vascular wall. Now, the Itat Krible, or the perivascular spaces, or the Virchow Robin spaces. Now, this also forms very important. Even I used to consider these to be benign. But now we know that these contribute to morbidity due to small vessel disease. We see it very commonly. You'll see these white matter hyperintensities, which look white in T2. When you go on to the flare, they'll be hypointense. So that's one way to distinguish them from infarcts, if you look in the flare imaging. So just rapidly going to how do we prevent and treat, because I've shown you most of the way you're going to detect it. So I didn't take a separate section for detection. A number of clinical trials based upon the risk factors that we already know of, the chief risk factor being age, which cannot change, and that's a non-modifiable. Hypertension has been attributed very strongly to small vessel disease. So as understood, most of the clinical trials would be focusing on blood pressure control as well as antiplatelets, since there is occlusion involved in the small vessels. So there have been a number of clinical trials in patients with lacunar stroke. Some of those clinical trials with antiplatelets did not show major difference with antiplatelet therapies. And in fact, some showed increased hemorrhagic strokes like the SPS3, where they use double antiplatelets. But the antihypertensives in patients with lacunar strokes, definitely most of them have shown that lowering of blood pressure does lead on to reduced burden of small vessel disease. However, some caution needs to be employed. Even statin trials, the VitaTops, the big study which was carried out, and there is some decrease in the progression seen with statin. However, there are no robust studies which really point towards any of these agents, but we know there is benefit, since atherosclerotic disease causes benefit, and we are not talking of pure atherosclerosis over here and with small vessel disease. A note about hypertension, which I would like to emphasize, is that most of the clinical trials did found reduced progression with reduction of blood pressure. Some of them found no difference, in fact, in reduction in cerebral blood flow. Now, that's important. If we look at the cerebral blood flow, because a lot of patients, especially elderly, would be depending upon cerebral blood flow for the blood perfusions. And since it did not lead on to lowering of hypertension, did not lead on to reduction in cerebral blood flow, it is considered to be safe to give blood pressure lowering. However, the caution that one has to employ is patients who are greater than 80, because here severely the brain perfusion may get affected. So do not lower drastically the lower blood pressure in elderly in asymptomatic. If you, of course, there are other indications you need to do that. And in the CADASIL, especially CADASIL, remember, I have not taken the genetic part of the small vessel disease. I've only taken the sporadic. The hypoperfusion is greatly dependent upon the blood pressure, and lowering of blood pressure in CADASIL is not recommended at all. It can lead to hypoperfusion and greater increase in infarcts. So as far as the treatments are concerned, there are certain emerging targets which would mainly focus on the blood-brain barrier integrity, vasoreactivity, compliance, because like I mentioned in the beginning, the major pathology lies within the blood-brain barrier, and that's where most of these studies should be targeting. And what needs to be probably done is the basic research, which is usually carried in animals, should reach the bedside. Most of them do not. Some drugs have proven some benefit, like Dr. Padma mentioned about cilostazol. So cilostazol seems to be a very promising drug even in small vessel disease. The trials for recurrent stroke, which have now come in, the Japanese trial does show some benefit with not much harm being caused by it, but trials on the cognitive decline are still ongoing. Nitric oxide, the ENOS trial being one of them, might benefit the small vessel because of the effects of not just vasodilatation, but anti-inflammatory and improved blood-brain integrity. So looking at small vessel, still trials are ongoing. The ENOS component, which was looking mostly for large artery strokes and the effect of strokes, did not mention much about the small vessel disease. So these are the various trials with the cilostazol and nitric oxide being going on. I forgot to mention the lifestyle changes which also need to be carried out. Apart from hypertension, smoking has been associated with a big burden and it's been closely associated with worsening of small vessel disease. Since it and it predicts small vessel lesion burden in patients with sporadic disease. So very strongly, smoking should be attempted to make for smoking cessation in patients with small vessel disease. It's not just a factor for atherosclerosis, but small vessel disease too. Sticking to the usual lifestyle, healthy lifestyle that we talk of in stroke, exercise, a good diet, and guideline-based vascular risk reduction. It also not only prevents small vessel disease, it helps in cognitive decline, as prevents cognitive decline, along with vascular risk factors, both of them. So that thing needs to be emphasized to patients, how a regular exercise and healthy diet is important. Just a word about lacunar strokes and thrombolysis, since that again is an important aspect that one need not forget. It needs to be remembered that lacunar strokes did not have enough evidence from the time the NINS trial was done, because they did not distinguish the stroke subtypes if you read the full trial. And they did not use MRI, they only used CT at that point of time. So most of this data which we initially had did not include lacunar strokes. And in fact, it was many times I've been asked this question by residents and physicians alike, that why are we treating strokes which don't have a vascular occlusion, which is a lacune, for example. So that always stayed a big question, where if there's no clot, what are you opening? And however, there were studies which actually with 7 Tesla MRI, which showed that the small vessel disease also had a perfusion following TPA. So that theory is not right, that you're not going to open the occluded small vessel, since there is lipohyalinosis. And it is believed that it may not be useful, but now we have enough data. So looking at that, theoretically, there are microthrombi which are formed inside the small vessels, and less of these emboli could be responsible for improvements. And a retrospective study did show that there is an improvement in lacunar strokes following the thrombolized patients. If we look at this, the MRS distribution in the thrombolized group was better. Looking at MRS 0, 1, and 2, the shift was much better. But this was retrospective. If I look at a recent SITS data, which was data from our center, was also included in the study. it clearly showed that IVT treated lacunar stroke in the adjusted analysis definitely had a better outcome in terms of MRS 0 to 1 and 0 to 2 at 3 months. And if a meta-analysis was seen, most of these studies favor the use of thrombolysis in lacunar strokes. And the wake-up trial you're all aware of, it shows benefit using a flare diffusion mismatch. It did show a benefit towards the TPA or thrombolysis in lacunar stroke. So we have enough accruing evidence. If you look at the shift analysis, the MRS 0, 1 to 2 is bigger than the placebo, and it's almost paralleling the patients with lacunar versus non-lacunar strokes. So what do we look in the future? Like I mentioned, trials which should address interactions between blood-brain barrier dysfunction, which I talked of earlier, reactivity, pulsatility, vessel wall damage, interstitial fluid drainage, and function of the perivascular spaces. So basically, something which focuses on the basic pathology rather than just looking at hypertension control and antiplatelets. So statins are believed to do that, and that's why statins have been the subject of clinical trials. So trials which may maintain endothelial function, otherwise still more robust trials to which improve the risk factors and lifestyle improvements, and need to be still carried out. And correlations with pathology and brain banking with data linkage, since genetic predispositions are well known, and we need to do data linkage with that. So just take home message, remember that it is not a benign thing. It is nothing which is sitting there silently, and there is a lot of effects which are not just restricted to the site of the infarct, but to the rest of the brain. And remember, 1/4 of all strokes, age-related cognitive, physical, and mood decline are attributed to SVD, and 50% of all dementias can be attributed to small vessel disease. We need to do effective management with lifestyle changes and risk factor control. And remember, IV thrombolysis also works in small vessel strokes or lacunar strokes. So do not please think twice when you get a lacunar stroke. Thank you.